So, good afternoon in California and good night here in South America. It's a big pleasure to interview you and a big honor. We are very amazed with the stuff that you created and truly pioneer work. And in this area that actually I love. I think it's the way to go, and it's expanding the limits of orthodontics. So we sent you 5 questions, which I'm going to ask you, and we're going to start with the first question. I'm going to read it in English, and then I'll let you answer it. What are the advantages of the Moon MSE, and when should it be used? That would be the first question.
Well, first of all, thank you for the invitation. It's really my pleasure to talk to you and talk about some of our findings. I love to share what we have discovered over the years. So when it comes to MSE, it started back in 2004 when microimplant came to the United States for the first time. And the whole idea was, let's create a bone expander rather than tooth bone expander. So that was the main advantage there. And as we evolved and developed further, we realized when you have a bone expansion, whether you're dealing with the children or adults, you're getting much better skeletal expansion without the dental alveolar side effects. And many people ask, why should you use MSE for children when you can do similar things with the Hyrax or tooth bone expander, which is quite true. To this day, I still use Hyrax or Haas. However, in 3 categories, even in children, I would prefer MSE. And those will be, number 1, those children with a very high steep angle, mandibular plane. So vertical control is better with the MSE, more parallel expansion, so we can control the vertical dimension in these cases. Number 2, we have a lot of class 3 cases in California, and when we are planning on doing expansion as well as a protraction, we like to have a bone protraction. So those class 3 skeletal cases, even in children, I use MSE.
Do you use it with the Alramec protocol for the class 3 children?
No, I don't, because MSE actually disarticulates just about every perimaxillary suture. So we don't really have to go back and forth. I've done that a couple of times in adult patients. It's quite violent with MSE, unlike with the Hyrax. So that technique was developed more for tooth bone expansion. With the bone expander, I think we have to be quite careful because you can create potentially a huge hemorrhage in the perimaxillary area. So I rarely do that. Okay, and those are the class 3 cases. Another category that I prefer MSE over tooth bone expander in children will be the patients with the nasal airway obstruction, because we have discovered that we can get much better nasal cavity expansion with the bone expander than tooth bone expander. So other than those cases in children, typical traditional expander works just fine. In adults, though, when we get up to age group where traditionally SARP was indicated, many of these cases we can actually do this with the MSE without the surgical assistant. So those are the differences. But even in surgery, when we have a SARP patient, I much rather use MSE than Hyrax, even with the surgery, because I have a more control of the hemimaxilla. So instead of 2 hemimaxilla segments flaring away from each other, MS can actually keep them together and make more bodily movement. So I find MSE to be more useful even in surgical cases.
Let me ask you something about the nasal airflow. This is something I already asked a few other people, and I do a lot of SARP, and I do a lot of that expansion. And I think that expansion is the new change in orthodontics. About airflow, do you feel it's more of a nasal airflow than oropharyngeal change? And I'm sure you're aware of Juan Martín Palomo's paper on the angle, I think 2013, and he saw more on, just on regular expansion cases. He saw more changes for airflow for the nasal cavity, but not as much for the oropharyngeal. So, what's your opinion on that?
Okay, so we weren't really interested in nasal cavity or airflow at all at the beginning until we start hearing patients telling us that they can breathe better. Initially, we thought it was just an anecdotal thing, but then there are too many people telling us that. So being a researcher, we decided to measure. So there are, several things we measured. Number one was volumetric changes. So in nasal cavity, we found out that with the MSE, not only the ANS, anterior nasal spine, splits open, but also posterior nasal spine splits open just as much, which means we're getting good posterior expansion with MSE, which is not the case with the parallel expansion, which is not the case with the Hyrax or even some of the other MARPEs that anchors in the anterior part of the nasal cavity, or
you get more of a V expansion.
V extension more in the anterior, not so much in the posterior. So maybe there are still traps in the posterior area. So these are the kind of things that we start to find out. Another important thing that we learned about MSE was that not only the inferior, but also superior part of the nasal cavity expand quite a bit. So the entire nasal cavity volume increases, and that has been well documented. Next thing that was quite interesting was, as you have mentioned, what about the pharyngeal airway? Because we were only looking at the nasal cavity width change or volume change, and the segmented air volume out of CBCT, we start to see notice some differences in size and the shape of the pharyngeal airway before and after the expansion. So we looked into it and we realized about 80% of the 80% of the time, pharyngeal airway also thickens with the nasal expansion. So I think a lot of times we used to look at the pharyngeal airway and determine whether a patient has an airway issue or not. Maybe this is the result of nasal airway obstruction. So I'm thinking reverse now because of some of the data that we saw. So this is something we're looking into. We want to have a cumulative data and see what changes are actually occurring in pharyngeal airway and why. I mean, I can come up with the 3 different reasons why pharyngeal airway will get larger. One of them is a mechanical property. If you have more input, obviously balloon's going to get expanded. The other can be a tissue stretch. If you increase the posterior palate, soft palate's going to stretch. That's going to change the dynamics of all the soft tissue within the pharyngeal airway. Number 3, when palate gets larger, possibly tongue may be positioned more superiorly, which will stretch the pharyngeal airway, will also increase the size of the pharyngeal airway. So those are sort of the 3 working hypotheses we have. So we're kind of actively looking into that. So we don't have conclusive data yet, but that's something very interesting fact that we're looking into. And that's just a volumetric analysis though. However, we need to do more dynamic airflow measurement. Just because you have a larger volume doesn't mean you can breathe better. So first thing we did was we bought this gadget that measures the airflow through the nasal cavity by having patients inhale like this through the tube. And we learned that significantly people can inhale more volume of air after the expansion. And that was one study we've done. The other one we have done was actually computational fluid dynamics study to see if we can reduce the air resistance and also reduce the air velocity so that it'll be easier for patient to breathe in and out. And we learned that there were 67% reduction in air resistance and also the travel velocity. So this is a quite significant finding, and we have a sample size of 50 with fluid dynamic studies. That's quite astonishing. So at the moment we're preparing a manuscript for publication, and we're quite excited about this. And there's a third aspect. Many people ask me about this. What about deviated septum? So there are a couple of articles, I guess, out there that are saying that with expansion, deviated septum is self-correcting. Within that, we did not find that at all. Deviated septum was still deviated after the expansion. However, we learned that the airflow through the lesser as well as the greater side significantly improved. So airway still improves even within patients with the deviated septum, but we don't necessarily correct the deviation of the septum.
That's great. That question that I asked you, you already answered, and I think what you're doing is very useful, because I think with all these airways, you have the dynamic and the static measures, and honestly, I think the static measures are not much. They don't give much information, because what happens if you do the CBCT and the patient was inhaling or exhaling, and how will it change? And you're just looking at a fraction of a second. It's not like a function. It's not like a functional study. So what you're telling me, that you're getting more into dynamic, makes all the sense in the world, because you really would know what's going on with the breathing.
Yes, you're absolutely correct. If you take the CBCT while you're inhaling versus exhaling and also swallowing, same individual, you're going to have a completely different volume in the pharyngeal airway.
Exactly.
So we're assuming the 15-second exposure, patient was inhaling and exhaling in proportional, the differentials. But with that, each patient, the comparison will be just case report. In order to summate the information, you're going to need a large sample to work out the variables. So that's why we thought that dynamic measurement is a much more useful clinical information.
Of course. The next question I wanted to ask you is, how do you correct the sagittal in class 3 patients, starting with the MSE? And I would like also for you to compare it to other methods like Hugo de Klerk, Bollard plates, and other stuff that is out there. I want you to describe your technique and also to compare it to other things.
So one thing we must understand is not all MARPEs behave the same way. We call any expander with a bone anchor, we call that MARPE, microimplant assisted rapid palatal expander. But depends on where you place the anchor, depends on how you expand, the result can be quite different. So because of the results are different, the way the rotational way the skull expands away from one half to the other is quite different as well. So one thing that I know how other expanders behave, but we did the extensive study with MSE, so we know how MSE behaves. So that's why I put up this photo here. So MSE's got fulcrum. When you look at it from frontal view, fulcrums are over here, and two hemiskulls rotate away from the fulcrum. If you look at it from axial view, you can see on the top view here, it's near the TMJ. So two halves sort of rotate forward and outward. So maxillary position at the end of expansion is significantly more forward than before. So in those minor class 3 cases, the class 3 relationship between maxilla and mandible can be self-limiting. However, when we are dealing with more significant skeletal problems, we have to provide protraction force as we are expanding. And one thing about MSE is our CBCT renderings reveal that all perimaxillary sutures that disarticulate get loosened up. So when we add protraction device along with the expansion, we get tremendous forward movement of not just maxilla, it's actually entire mid-face. So it's almost like a left forward 3 like movement in forward direction, tremendous forward movement, which is very beneficial for mid-facial deficient patient because you can get infraorbital area to come forward as well. So that's one.
Even in adult patients, correct?
Even in adult patients, but the amount of forward movement that we were able to create was far less. There are two components to protraction. One is the growth factor. By expanding, loosening things up, and also protracting at the same time, there's a distraction-like movement, kind of like a surgical distraction without the surgery. The other one is a growth factor. We're stimulating growth. We're encouraging upper face to grow forward. So in children, both of those things kick in, and then you get tremendous forward movement. Profit, Peter-Nan, all said, do not expect more than 4 millimeter forward movement of the maxilla with the traditional approach. With this one, consistently we're seeing 8 millimeters, 10 millimeters in younger children. When we apply the same concept to adults, now we're not dealing with the growth at all. We're only dealing with the surge distraction like forward movement. In that case, so far, we only have a few case reports, but one of the lady, 24-year-old lady we treated with expansion and protraction, we were able to protract the entire mid-face in forward direction by about 3 millimeters. And how far can we move forward in adults? We don't know yet. But you know, those are some of the good cases we've seen. Obviously, it requires a lot of cooperation from patients and so on and so forth. But we learned that it is possible to protract the mid-facial structure, even in mature patients.
You know, I have another question that it was not written, but I thought about it afterwards. I didn't send it to you. It's when we use the MSE, and you're supposed to, you have choices of either 11 or 13 millimeter screws. Very rarely I've used 13. Most often I use 11, which they work fine, because what we do in our cases, we take after the expansion is placed, we take a PA-SEF and we see that the screw, everything works fine. And to start with, we have a CTCV and we measure in the CTCV. In which occasions do you usually get to use these 30 millimeter screws?
So those are the ones that we use. I say about 95% of the time, 11 millimeter is adequate. Once in a while, we run into a situation with the extremely thick palatal bone that we know for sure 11 is not going to reach the second cortical layer. So rarely, but once in a while, I have to go with the 30 millimeters. And other cases where palatal voltage not even, but rather like this. So when we place MSE straight like this, you have a larger air gap on one side over the other. So those are the cases I may choose to use 11 millimeter screw on one side and 13 millimeter on the other side, so that we'll get the adequate bicortical engagement. So again, you're right though, 11 millimeter will take care of most of the patients. Let me go back quickly comparing MSE with the other MARPEs when it comes to protraction. I'm well aware of de Klerk's approach. Actually, I had a debate with them in one of the meetings in Japan. And I think the advantage of MSE over his bone plate in class 3 elastic is that we are able to loosen the perimaxillary sutures. So we can promote the protraction of the maxilla, because the heat system, he doesn't expand the maxilla. So I think there's one major difference. Another difference is he uses class 3 elastics. I use a protraction device, which is usually face mask. So force factor against the maxilla is quite different. So in the case where you're dealing with the brachycephalic cases, where rotation of the maxilla, meaning posterior part of the maxilla dropping down, is beneficial in correcting class 3, the Klerk's methods works very well. However, when you're dealing with the high angle class 3s, where you don't want to elongate the segment, I am very area of using his system. So, you know, after we debated, my Japanese colleagues determined the best way really is MSE with de Klerk's class 3. That way, you don't have to force people to wear face mask, but you still loosen up the perinaxillary suture, which I agree.
Yeah, you can put four plates in the mandible and pull against the MSE. It should be fine. You know. The other thing I want to ask you.
Right. So the do that. I do it that way.
The other thing I want to ask you, I saw one of your in one of your writings that when you pull straight from the band. You don't like to solder arms. Can you explain us why?
Yeah. So initially, we had soldered arms because that's how we used to do it with the traditional face mask approach. You wanted to have arms near the canine area so that your center, the force factor will go through the center of resistance. As we do more and more of these things, soon we realize concept of center of resistance is really dentally driven. It's a tooth-driven concept. You're trying to look for center of resistance of each tooth and all the teeth as a group. When you have a bone anchor buried onto the palatal vault, none of these things really matter. What you're interested in is a center of resistance for entire mammary bone. So we decide to create a finite element model of a force vector from the arms from the molar tube directly with the simulated system that has a bone anchor at the palatal vault. The result was exactly the same, makes no difference. So if you want to use the arms, feel free to do that. That's okay to do it. I like to keep things simple, so I like to go straight to the molars and stretch forward.
And you can have a longer stretch of the elastic from the molars to put more pressure, right?
Right. So you can actually generate more protraction force using the arm, using the hooks. It's easier, more convenient for patient, but you'll end up applying less force. So people ask me, how much force is adequate force? How do you create orthopedic force? Answer is quite interesting. Initially, when I thought about it, because we learned orthopedic force is 300 to 500 gram or something like that. So what defines term orthopedic force? In orthodontics, orthopedic force is enough force to create hyalinization, which means kill the bone cell, so that the force you're putting onto the teeth will be transmitted to the bone. Well, when you have a bone anchor, any force is orthopedic force. 10 grams is orthopedic force, 1K is orthopedic force. So it doesn't really matter. So the result that we saw from our patient is more force the better, longer wear the better. So force factor doesn't matter at all. I say the highest force your patient can tolerate is the best force. So with the children, we start with something lighter, something like 200, 300 grams. If they can tolerate, then we double up. And I try to get up to about 500 grams on each side. And we get tremendous correction in a very short period of time. And when it comes to adults, mature patients, again, it's more like a distraction, not growth modification. Those cases, at minimum 500 grams on each side. Sometimes I double up and have a patient tolerate 1 kilogram of force in each side. Then we see pretty significant results. But see, we don't have to worry about damaging the teeth at all.
You pull straight, or do you pull with a downward vector?
Sort of a slightly downward vector. My main thing is stretch from the molar tube, comes right to the lips. I want to make sure that rubber bands are not irritating either the upper or lower lips, and will come to the bow outside. And that's a slight tilt, probably about 10-15 degree forward and downward slope.
Can you comment a little bit on the methods for aiding the expansion? I'm talking about mainly cortipuncture, and then if not corticotomies. The problem I do see with cortipuncture, even though I know a lot of people use it, is they have few studies. They're mainly like 1 or 2 case reports. So there's no much data published that I'm aware of. So
one publication my group, Suzuki, Sally Suzuki, one with me. on chord puncture. But there aren't many, you're right, I mean, there aren't many papers on chord puncture, probably because I am the one who proposed it at the beginning, but even myself, I don't do it that often. I only do it, so some of my colleagues do chord puncture every single time when they have a patient over 25 years old. I don't do that because my success rate with MSE is approximately 85% or so. So it's hard for me to justify doing chord puncture on every patient. So I usually do the MSE expansion without any assistant. And when I start to see that it's not going to work, and then I do the chord puncture, which is basically, there are two concepts in that. Chord puncture is mainly to weaken the resistance. So if you weaken the mid-palatal interlocking, then your expansion force can overcome the resistance. But there's another very important aspect of chord puncture. You're actually producing inflammation. So you're increasing, enhancing osteogenic activity. So those two things together kind of helps us to split the interlock suture. However, though, even chord puncture doesn't always work. Even after chord puncture, I still fail sometimes. And those are the cases where I will still use MSE, but have a surgeon actually disarticulate the mid-palatal suture and then try to split. This is chair side, not in OR. You usually use the piezotomy. And then when that doesn't work, and then they can actually score the buccal bone with the same piezotomy. That usually works most of the time. And if that doesn't work, then you have to go on full-on SARP. But even on full-on SARP, you rarely need to disarticulate the palatal suture. So that's why even SARP patients, I use MSE. But my steps like this, MSE, chord puncture, and then minor surgical assistant. And then if none of those things work, then we go to SARP.
You see, the problem from the concept, from a conceptual point of view, I have with chord puncture is that the resistance to expansion is not the mid-palatal suture, it's the circummaxillary sutures, the thyroid plates, etc. So from a practical point of view, I don't think chord puncture does much. Other than
so
what you said about the inflammation effect, you know.
So you can actually chord puncture the buccal shelf as well. We tried that. However, what I've done in Spain, we actually did a cadaver study. So we have a cadaver head, and then I did practice surgery. So we placed the MSE, and then we actually split the mid-palatal suture surgically on cadaver and split. And majority of the time, if I'm able to cut through all the way from ANS to PNS, I can split. But you're right though, even with the mid-palate disarticulation, because of the buttress bone, expansion is quite difficult. If you just not do the mid-palatal suture, just cut the peripone aperture and go all the way through, score the buccal bone, that works as well. But again, there's going to be some resistance from the mid-palate. That's why when SARP is done, surgeon usually they do both. So which one do you do first? Well, it really depends on what your aim is. If you want to increase the nasal cavity width, it is better not to touch the buccal shell. Why? Because you want hemi-face, hemi-skull to rotate away from each other. You don't want expansion to occur below the cut. Okay, if you have the intact buccal shell, you're gonna get entire mid-face rotating away. So actually your superior volume of the nasal cavity increases more. And we actually have a CBCT data comparing SARP and MSE expansion. MSE expansion actually gives you more nasal airway volume than with the SARP. So with
because it goes all the way up. SARP cuts the maxilla here, so you have a shorter segment to work with, correct?
Right. Your increase will be at the bottom 1/3 of the nasal cavity. With the MSE pure expansion, if you're successful, then you can get a much larger volume. So when we do MMA for those sleep apnea patients, I often suggest doing MSE expansion first, and then double jaw, advancement.
Yes.
Because I have data enough to show my surgeon.
Not only that, but once you expand the maxilla, you have more room to advance the mandible as well, right?
Absolutely, absolutely.
Let me ask you another question that I have. I've been reading, I read a paper comparing a lateral wall expander, but the bone expander, similar to the pen expander, other expanders. I use a lot the pen expander compared to the moon, and they talk about some periodontal effects on the first molar from the solder arms. What's your opinion on that, and how can you avoid that perio problem?
So when they talk about MSE pushing against molar, either they're looking at the old design MSE where we had the stiff arms, so that when you expand and screws fail, the expansion force can potentially go to the molars. However, with the soft arms we have now, it is a very limited amount of tooth movement you're gonna get, unless the screw really fails and you keep expanding, which rarely happens. When as a orthodontist, when it fails, you stop expanding. So we had our latest publication, Progress in Orthodontics, actually show that percentage of a skeletal expansion versus bone bending and tooth dental movement with MSE. When we looked at our 50 successful cases with MSE, about 96% of expansion was from skeletal component. So we're not necessarily worried about the dental movement. If you're really worried about it, you can cut off the arms and then it's gonna be pure bone expander. It's just your failure rate is gonna escalate because the little screw in the middle is very unstable. So during the expansion, when you try to disarticulate heavily interlocked suture, the jack screw is gonna go through a lot of torsion, which means the 4 implants that are holding the jack screw will dance with one another. And that's what causes main failure. That's why we rather have the arms, even if there might be slight molar movement, which is very easy to control. Once suture splits, you can just cut off the arms and decompensation happens immediately. So that's why we have the arms.
So
and I do
that used to happen more with the MSE1, correct?
Right.
Not with the MSE2.
No, because we have a copper soft wire now.
I see. The other question I want to ask you is, I read an article comparing when you get bicorticality of 2 millimeters or when you get less, like 1 millimeter. So from a clinical standpoint of view, how can the clinician be more towards 2 millimeters versus 1? Because there was a big difference in stability of the appliance. So for the everyday orthodontist that is not doing research like you are doing, how can you make sure that you have those 2 millimeters?
So our study actually showed that whether you are to the nasal cavity a little bit or all the way through and through, it makes not much difference at all. But there's a huge difference between monocortical versus bicortical. So as a clinician, you just have to make sure that you're bicortically engaged. It doesn't really make any difference whether you're penetrated 1 millimeter, 2 millimeter, 3 millimeters. As long as the screw is inside the nasal cavity or touching the lining layer of the nasal cavity, you're pretty stable. So clinical tip is this: as you're inserting, and do not use the motor driver, use the manual one so that you can go slow. And as you get to the second layer of the cortical bone, insertion becomes quite difficult, quite challenging. It becomes very tight. And as you slowly turn the driver, you'll feel slightly less tightening, less resistance. That's when you're right through the second layer of the cortical bone. Usually at this time, patient will tell you their nose itches, or some sensitive patient may say, ouch. This is when you're through the second layer, and you don't have to go any further. Even if you have a 2 millimeter extension at the palatal side, you don't have to try to screw in all the way. There's no need to. So that's what I typically do when patient says, okay, I feel it up in my nose. It feels like I feel like sneezing, but I can, kind of thing, and then you can stop. However, is it okay for you to screw in all the way? Is it harmful for screw to penetrate through the nasal cavity? Absolutely not. So some patients are not so sensitive, they won't tell you anything. And you finish your insertion, you take CBCT, and you realize all 4 screws are sticking into the nasal cavity. That's perfectly fine. I had several ENT doctors who were my patients confirming that that shouldn't be a problem at all, because a lot of the procedures they do in ENT is far worse than what we do. And after thousands of these cases, I haven't had a single problem with infection or anything like that from the nasal cavity side. Any infection will occur from the palatal side, not so much from the nasal cavity side.
And the last question I want to ask you, because I don't want to take out much of your time, is once you open the diastema, all traditional orthodontists used to wait 4, 6, 8 weeks to close it. I see that sometimes you don't wait and you close it sooner. Is that correct? And can you explain me why?
Yes, when I graduated from orthodontic school, we were told to wait 3 months. Some instructors said wait 6 months after the SARP procedure, sometimes even Hyrax with a large gap. It never made sense to me. When we do extraction cases, we take out the premolar, we start moving canines right away. When we take out the wisdom teeth and with the MS dissociation, we do it right away. And how come we have to wait so long, especially with a huge diastema? You know what happens? There's going to be a labial concavity. It's going to be so difficult to move the roots into the very narrow trough of cortical bone. And eventually, you're going to lose papilla. So it never made sense to me. So from very early stage of my career, I started very carefully closing up the spaces, even after SARP. And I learned, actually, teeth move much faster, root movement is easier, I get less root resorption, and most importantly, I don't lose papilla. So I discovered this. And then later, glucodonics came and told us there is a RAP, regional acceleratory phenomena. So when there is a trauma, you should move teeth because teeth will move faster and better. So it's exactly that concept. So what I do is as soon as I'm done with complete expansion, then I put the braces on right away with a very light pressure. Slowly I squeeze and then close up the gap. And then once crowns are together, I put cable bands so that I can bring the roots together, lace them together and bring the roots together. And usually within first 4 to 7 months, I'm able to complete the space closure.
And the question connecting that question with it would be, how long do you leave the screw after you're done the expansion for bone formation?
So bone remodeling process, as you know, takes about 3 months, but it's going to be soft, woven bone. So to make sure that we have enough bridging between right and left side, I leave the jack screw portion of the MSE in place for about 6 months. So during the time, if you want to cut up the arms so that you can move the molars or the anchor teeth, you can. So either you have a choice of either leaving the molar bands attached to the MSE, use them as anchor for whatever your orthodontic purpose, or you can cut up the arms and move the molars. But the jack screw with the 4 implants has to remain in place for 6 weeks. Somebody asked me, do I know for sure that there is a complete new suture formation within 6 months? No, because I have not done any more study. However, later, I've been doing this for almost a decade, and then I met with what's his name? Name escaped me. He works with the Benedict. He actually showed that publicity data showing that after about a year, he took another CBCT after good expansion. He saw bone that's looking more like a Swiss cheese. So I guess it takes a while for new suture to form 100%. But I always removed MSE after about 6 months, and I haven't seen a major relapse at all skeletally. So I guess after 6 months, even if suture formation is not 100% complete, there's enough bridging for the stability. So I still keep it in there for about 6 months. If patient can tolerate, they want to leave. You want to leave longer, that's okay too. Sometimes I leave it in there longer if I want to use it as my anchor unit. For example, if I want to do MS retraction or use intrusion type of thing in open bite cases, I may leave the Jextropy in there for much longer.
Great. Okay. So I thank you very much. I don't want to take out more of your time. I'm looking forward to seeing you maybe in Boston if we have a meeting. I don't know if we're going to get an AAO. I saw that you're going to give a lecture, and we'll see what happens. With this COVID-19, everything changed, and I'm really looking forward to going to UCLA and spending time with you. I think you've changed orthodontics with your concepts, and I want to go at least for a week and stay there and learn from you. Okay.
Well, thank you. I will be in Boston. Hopefully, the AAO will be in person rather than virtual. And if any of your students want to learn more about how to get MSE incorporated in their private practice, actually, I actually listed the web link up there. I'll be giving a 3-hour talk sponsored by Foresight Harbor. So it'll be very practical information, like what size to buy, how to place, how to utilize the lab, what you should be doing as a doctor, what will be the lab's responsibility, so on and so forth.
That's a link for registering to this lecture, correct?
Right.
Okay,
Right.
Great. Okay, thank you very much, and thank you very much for your time.
Thank you so much. It's getting late late down there, so good night.
Thank you very much, Dr. Moon.
Right, bye-bye.
Thank you so much. Good night. Thanks.
Bye-bye.